Hi, I'm Jonah Comstock, Editor-in-Chief at pharmaphorum. I'm here at ASCO in Chicago, day 2. I'm joined by Dr. Hans Lee from the Sarah Cancer Research Institute, and we're going to talk a little bit about some ASCO data that you've got. You're an investigator on the Linker ALS trial. So tell me a little bit about that trial, the rare disease that you're studying, and what the data showed.
Yeah, thanks, Jonah. So the Linker AL2 study is a phase 1, phase 2 study evaluating the BCMA bispecific by linvoseltamab in patients with relapsed refractory light chain amyloidosis. So just a little background for the audience. Light chain amyloidosis is a rare clonal plasma cell disorder associated with significant morbidity and mortality. And importantly, there are no approved treatments for relapsed refractory light chain amyloidosis currently approved. And so in this study, 20 patients are enrolled so far in the phase 1 parts of the study. All had previous treatment with the median of 1 prior line of therapy. 60% of patients had prior daratumumab exposure. Patients then received linvoseltamab at 2 different doses, either 80 milligrams or 240 milligrams, for a minimum of 12 cycles and a maximum of 24 cycles. So far, the results have been very encouraging to date. What's really striking is the efficacy that we're seeing early on in the study. So 100% of patients have attained at least a hematologic very good partial response to therapy. 90% of patients have attained at least a hematologic complete response. And it's really not just the depth of response, but the speed of response that we're seeing. So the median time to onset of hematologic CR is 1.5 months. And the median time to normalization to involve free light chain is only 2.1 weeks.
Wow.
In addition, we're seeing a very encouraging safety profile. So no dose-limiting toxicities have been observed to date. Cytokine release syndrome is the main adverse event that we're seeing with the study, which is common with this class of drug. Although all CRS events were low grade, grade 1 and grade 2, no grade 3 or higher CRS events. So this is a very encouraging results of this initial report of this phase 1 study. And given the promising results of this study, the phase 2 part of the study is currently ongoing with potential registrational intent.
Yeah, I mean, you don't usually hear 100% anything at a conference like this.
Yes.
And the speed of response is really fascinating too. So, and it's not even as if you have to compare to standard of care, because as you say, there is no standard of care for these patients.
Absolutely. And I really do want to emphasize the point that you just made of not just the depth of response, but the speed of response. So speed of response is everything in light chain amyloidosis. Time is tissue, because these light chain fibrils are depositing into the organs of the body, causing end organ damage, leading to morbidity and mortality. So we know that in just as a disease in general, it's really trying to reduce the light chain levels as quickly as possible. I think that's equally as impressive as the depth of response, and we're seeing both with this drug.
So you mentioned this is a rare disease. I mean, how rare is rare? How many? What's the patient population like that's going to potentially benefit from this?
So this is indeed a rare disease. Less than 5,000 people are diagnosed with light chain amyloidosis per year. Some people have concurrent multiple myeloma and light chain amyloidosis. Some people just have light chain amyloidosis alone. So it is a rare disease. It's an orphan disease. And I think this is why this trial, these trial results are so encouraging, because again, there are no options for relapsed refractory light chain amyloidosis in this patient population. It's often overlooked in clinical trials. And so it's great that patients with this disease have something potentially we could offer them that elicits such profound depth and rates of response.
Did that make it challenging to design a trial and find sufficient participants?
So light chain amyloidosis trials in general can be challenging to accrue to. Oftentimes they tend to enroll at major amyloidosis treatment centers, just because they do require a lot of multidisciplinary care, including not just hematologists and oncologists, but cardiologists, nephrologists, depending on the organ involvement. But I do also want to highlight that one really nice thing about linvoseltamab as a bispecific T-cell antibody is that it's off the shelf. So unlike other T-cell redirected therapies like CAR T therapies, which require a much more complex infrastructure to actually deliver the therapy, these types of drugs like linvoseltamab can be given to patients potentially in their local treatment setting. And so again, amyloidosis patients are from everywhere in the US and everywhere in the world. And so it's really, really important to have therapies that patients have access to in their local treatment setting.
Totally. Yeah, I mean, so would you call this a allogeneic cell therapy?
This is a bispecific.
It's a bispecific
T-cell antibody,
yeah.
yes.
But it's off the shelf.
It's off the shelf, yes. Meaning that It's just like a normal drug. You can give the drug to patients just like in their clinic. It's just shipped to the treating center and basically delivered to the patient.
Um, we're on day 2. I don't know how long you've been at the conference, but what are some of the kind of trends you're seeing and hearing? Outside of presenting your own research, what's your focus? What are you here to learn about?
Yeah, so my focus is on plasma cell dyscrasias, including amyloidosis and multiple myeloma. At yesterday's oral abstract session, there were 2 key phase 3 trials presented at the session, including the phase 3 successor study, which looked at a novel CELMoD drug called mezigdomide in combination with carfilzone dexamethasone versus carfilzone dexamethasone in patients with 1 prior line of therapy in relapsed refractory myeloma. Another study, the Majestic-9 study, looked at teclistamab monotherapy, which is a BCMA bispecific antibody versus standard of care options, PVD or KD. Both trials were positive studies which showed improvement of progression-free survival. Notably, the Majestic-9 study also showed an improvement of overall survival as well. So both trials are going to be practice changing. I think it's really, really exciting that we have new therapies in myeloma continue to be developed that are really providing incredible responses and better access to better therapies for our patients.
Yeah, so there's really a shift happening in myeloma right now in terms of these innovative therapies and the effect they're having.
Yes, absolutely. It's a really exciting time in the field. I know we thought that progress was being made 10 to 15 years ago in myeloma, but that progress was really accelerated over the last 3 to 5 years. I think we're even talking about cure in myeloma now, just because we're seeing really unprecedented not only response rates, but depth of response with patients with these novel therapies in multiple myeloma. So I think this is all really great news for patients, especially with newly diagnosed myeloma, but even with relapsed refractory myeloma, just because we do have better therapies with these patients today.
Great. Well, thank you so much, Dr. Lee. Really appreciate you taking the time to chat with me.
Thank you.